So, did you like the background on my backyard?
Yeah.
Doing a lot of work on it during the pandemic and all. Okay, we are recording now. And like I said, this is going to be short and sweet. We're going to talk about the neurologic disorders. This is kind of an introduction to neurologic disorders. It's not an exhaustive study by any means. But we want to talk about a couple of things: Parkinson's, dementia, Alzheimer's, and what you're going to deal a lot with are stroke patients, or CVA, cardiovascular accident. It seems to change its name every 10 years. I think it's still calling it CVA right now. Remember, you see the angry bug, might see it again. Yay. So this is what we're going to be covering. Now, when I say quick review of neurological system, we're just going to talk about the lobes of the brain. We're not going to go into any detail on, nerves, axioms, dendrites, anything like that. You got most of that in your anatomy physiology, but they're going to be hitting on the sympathetic, parasympathetic nervous system, probably a lot in your pharmacology, because you have cholinergics, anticholinergics, and all that stuff. Most of them affect the sympathetic, parasympathetic nervous system in one way or another. So, diving right in, there again, y'all know the big three main components of the brain. You've got the cerebrum, the big surrounding area, the cerebellum below that, and then the brain stem. This is one of my favorite words down here, medulla oblongata. I don't know who came up with that, but that is just super cool. I'm going to turn my pen on here so I can circle things if we need to. There we go, medulla oblongata. That should be, sounds like a Jeopardy question. It's not going to be on the test, by the way. We're just going to look at the four lobes of the brain. You have the frontal, the parietal, temporal, temples, and occipital in the back. Each of these has a different function. And the reason we're talking about this is when somebody has a stroke, it's going to be in some area of the brain. So if they have, say, a stroke in this area of the brain, they may have trouble speaking or receiving. For example, the Wernicke area. If they have a stroke in this area right here, they might get what's called expressive aphasia. Aphasia just means you can't express. So when somebody has a stroke and they develop expressive aphasia, you'll ask them questions and they'll look at you with a blank stare. They know what they want to say, but it can't come out. It's like a gag order. They just can't get it out. That's opposed to somebody who, say, has a stroke in the auditory receiving area. He can get receptive aphasia, where he can talk and he knows, but when you talk to them, what you're saying makes no sense. It's like you're talking in a foreign language because that area of the brain is not coordinating it. And we're going to go into more detail on these areas when we get to CVA. Here are the four lobes and what each of them does. I might bounce back and forth, but the frontal, this is the frontal area right up here. That controls your cognitive functions and voluntary movement. Now, I'm sure all of you have probably come up against or seen in the movies or heard about where they used to do, and my cognitive functions just went south because I can't remember what it's called. They stick a needle up your nose and they stir up the contents of your frontal lobe. What do they call that?
Lobotomy?
Oh, yeah, lobotomy. That's what I'm trying to think of. I think I had one sometime in the night. But they would do a frontal lobotomy on these people to stop things like violent actions and stuff, but it would work a little bit too well and kind of just turn them into a zombie. So they don't do that anymore. The parietal lobe, which is about midsection of the brain. Now that processes information about temperature, taste, touch, and movement. Very important part of the brain. You may want to remember that one. Basically, a lot of your cognitive facilities right there. The temporal has most of your memories, and it helps integrate the memories into temperature, taste, touch. In other words, you touch something hot and your temporal lobe will say, oh, last time you touched that, you got burned. Oh, okay, I better not touch that. So these two kind of work together. And occipital, one of the primary functions there is vision. People will get bonked on the back of the noggin. They'll see their vision go tunnel vision or just kind of disappear temporarily. Angry bug. But enough about that. The autonomic nervous system, you've probably been talking a lot about that in pharmacology because so many of the drugs affect the sympathetic nervous system or the parasympathetic nervous system. Sympathetic nervous system is your fight flight. You're walking down a dark alley, someone jumps out in front of you with a knife, your sympathetic nervous system goes into high gear. It shuts down your digestive tract immediately. It stimulates adrenaline, epinephrine, norepinephrine, and dopamine get secreted in your body, and you're just like, whoo. But there are other drugs also that can do the same thing, methamphetamine for one. And then the parasympathetic nervous system is the rest and digest system. This is the one that calms you down, slows your heart rate. You focus on the digesting of the food and going potty. And acetylcholine is the one that works on that. And there are several drugs that are associated with that as well. We're going to dive into the dysfunctions. Now, we're going to say a couple of them like Parkinson's and dementia. Parkinson's and CVA. These mostly affect the body systems, not so much the person's mental status. But when we talk about dementia and Alzheimer's, those primarily affect the person's mental status. And those are the people that are really quite difficult to work with, or can be very difficult to work with. In Parkinson's, basically your dopamine producing cells are degenerating. And we even have an exam, radiological tests that can actually show the atrophy of those dopamine producing cells. So it would make sense if we had a drug that produced dopamine that would help the condition. And when they came out with that in 1969, they thought L-Dopa was a miracle drug. Unfortunately, it only works for a short time and begins to degenerate. So that is unfortunate. The features of Parkinson, we're going to talk a little bit more about that in the next slide, so I'm going to skip over that right now. Here's just some stats about it. It's about 1.5 million Americans have it. All of us have probably met somebody or have someone in the family or had a patient who was Parkinson's. And it's frustrating because mentally they are still here. They're sharp as a tack in their mind, but because of the degeneration of their voluntary muscular system, they can't walk right. They have difficulty talking. They have nervous tremors, and we're going to talk about some of those here in a minute. So it's a very, very frustrating disease for the patient. I want you to just keep this in the back of your mind as a nurse. It's frustrating because they may walk like they're an idiot. They may sound like they're an idiot, but they're not. In their mind, they're still sharp as a tack. They just can't move properly and they can't get that information out. So you don't want to make the mistake of thinking because this guy is having difficulty talking that he doesn't have all his mental resources with him. He does. A couple of statistics here. Average onset's about 60 years old, most common in white males. Not always 60. We all know about Michael J. Fox, great actor, loved his stuff. Um, Developed at a pretty young age, and he's still having to deal with that. And it's really sad to see somebody degenerate Parkinson's. Etiology, basically, like several other diseases, we don't know. We don't know what causes it. Could be something in the genetics, could be something in the environment. Is there too much aluminum in our diet? Who knows? Nobody knows. But it does have a certain set of distinct characteristics, and those distinct characteristics, which we call the classic triad, is what we use for diagnosing the disease. And like I said, they also have radiology tests that can show the atrophy of the dopamine producers. So that kind of gives us a clue as well. Resting tremors, they call it pin rolling because they'll kind of do this with their fingers. Rigidity, they're very stiff when they walk and when they move. And they also have called drop foot. They have drop foot where they walk, their foot just kind of slaps down. And you'll see them walking around like that. Their foot just kind of goes plunk. And that also kind of ties in with the bradykinesia. That's a word you want to stick in your vocabulary. Bradykinesia is when their movements just become very slow and deliberate. They can't move around like we do. They can't dance or anything like that. Because of the dopamine reduction, it's very difficult for them to move the way that they want to. So that's bradykinesia. Angry bug. Dementia. I think I'm going to change these slides and deal with Parkinson's and CVA last and dementia and Alzheimer's first. Because dementia, we're not talking so much about deterioration of motor skills as we're talking about the actual cognitive features of the brain. And as it says right here, it involves intellectual deterioration. That's probably enough. That's probably the best definition of this. You could have mild dementia. You can have severe dementia. You might get some short-term memory loss. That's usually the first sign, is the short-term memory loss. That's why they say as people get older, you should do crossword puzzles and things like that to try to keep your memory sharp. And that's why you see us old instructors like Bill and I going, what was I just going to say? Long-term memory, usually long-term memory sticks around a lot longer than the short-term memory. You can't remember why you walked in the kitchen, but you remember what your favorite song was from 1978. Not you guys, of course. But it can impair your abstract thinking, impair your judgment. People in dementia can get themselves into a lot of trouble. I do want to point out that dementia is actually more of a symptom than it actually is a set disease. If somebody is suffering from dementia, they have a set of characteristics that we define as dementia, but that's not the cause. The cause is something different. So it's not an actual disease. It is more of a description of symptoms, a set of symptoms, if you will. And like this points out right here, Alzheimer's will account for about 75% of all dementia cases. Other causes, obesity, high levels of homocysteine. I don't know if they actually have a name for that. Anything that impedes the flow of blood to the brain. And there's also drug abuse and other things can also lead to this. We were talking earlier about alcoholics. Alcoholics can develop some dementia. It can also, as we studied in HIV and AIDS, the AIDS syndrome can lead to dementia as well. So it's more a description of a symptom than it is an actual disease itself, as opposed to, you might want to remember something on that slide there, as opposed to Alzheimer's, which is an actual disease. So you can have Alzheimer's and get dementia, but just because you have dementia doesn't necessarily mean you have Alzheimer's. There again, Alzheimer's is one of our nemesis in nursing, impairment of cognitive function. And this is probably one of the worst diseases we have out there because it's basically a slow deterioration of your mental state. It not only affects all your cognitive features like memory, judgment, abstract thinking, mood, behavior, changes in personality. It may not necessarily affect you physically. You can still get up and walk and talk, but when you're losing all these capacities here, that can make for some real problems. There again, I'm sure all of us at some point have known somebody with Alzheimer's or dealt with Alzheimer's patients. This slide is kind of silly because it describes stage 1 through stage 7 of Alzheimer's disease, but their descriptions are not so much, yeah, okay, quite a bit, well, moderately, and yeah, a lot. I mean, there's really no precise definition in there, if you know what I mean. So basically, you're going from mild to worse over a set of 7 stages. Now, I'm sure if I look it up and the doctors have a chart that says, okay, they've lost their short-term memory, they still have the long-term memory, their cognitive abilities are still good. Okay, they're in stage 1. Okay, the person doesn't know where they are. They get lost easily. They wander. You always hear the Alzheimer's patients wandering. Maybe they're in like a stage 5. And then it can really get to where the frustration of them not being able to comprehend what's going on about them can actually lead to a point where they can actually get violent. And that, I think, is the saddest part of Alzheimer's, is that they get so frustrated. In the back of their mind, they see everything is okay, but to the objective world, it's not. And they get frustrated with people telling them what to do, where they can't go, what they can't do. I'm a grown adult. You need to leave me alone. And they can actually become rather agitated. I won't say violent, but they can be very agitated. And that's a real frustrating for both the individual and for the caregiver. And you're probably getting into stage 6 or 7 when you get to that point. Treatment. There is no cure. We have discovered some medications that for one reason or another helps the individual with the Alzheimer's. Cholinesterase inhibitors, which you studied in your pharmacology, are probably the first line drug. But there again, these only work for the short term. Ultimately, there's really not much we can do about it. The most important thing that you will probably have to do as a nurse, in addition to keeping the patient safe, is education of the family. Letting them know what it is that they're in for and things that they can do with their family member to hopefully help slow the process as much as possible. Exercise seems to help. Cognitive therapy, which may be conducted by occupational therapists or speech therapists, and other programs. There's a lot of programs out there for Alzheimer's disease and the families of people with Alzheimer's to help them deal with this disease. It's really sad. Really, really sad. I might want to remember something on there. And don't worry, the PowerPoint that I put online does not have all my crazy lines all over it, so you'll be able to actually read it. There are some things to consider, nursing considerations with Alzheimer's. An early initiation of pharmacology, the sooner we can get the cholinesterase to them, it will delay the disease as much as possible. They're experimenting with different combination therapies that hopefully will help. And education of the family to help relieve some of the stress of the disease. There again, risk and diagnosis, depending on what stage of the disease they're in. Risk for violence, as I was talking about, they can get very agitated. They get very agitated because they're very frustrated and they act out, basically. Self-care deficit, they may have difficulty doing their activities of daily living. So you will have to help them with that while they're in the hospital, and hopefully educate the family so they can do that at home. Hopefully, if you can get them to socialize, especially if they're in the hospital, if you're in an extended care facility, like we were going to Garden Terrace, a lot of rehab there. And they had a common room for eating. Getting them out and socializing really helps alleviate some of that anxiety. And there again, it's tough on the family. Before I go on to CVA, are there any questions on Parkinson's, dementia, or Alzheimer's? I'll see if I can remember any of them.
I don't think so.
All right, let's dive into CVA.
Yay.
Yay! This is one that I dealt with a lot because most of my time in the hospital, I was ER. And in ER, we deal with a lot of heart attacks, which you always hear announced as code blue. And we deal a lot with strokes, which you always hear announced overhead as code neuro. And the reason they announced that over the loudspeaker is they want to prepare not just the ER, but radiology and pharmacology and respiratory, that we have one of these two people coming in, because there are a set of steps we go through with every patient. And I'm sure you're probably familiar with the heart attack or MIs that come in and the tests we have to run on them. I think you had that last year. Well, with strokes, what we want to do when they come into the hospital is we want to clear a path to get them to the CT as fast as we possibly can. And I'm going to explain why that is. So that's why we announce it over the loudspeaker, because we're getting ER and radiology ready to bring this patient straight in. There's two kinds. There's ischemic and there's hemorrhagic. And I will explain what the difference is. Ischemic is when you get the blood flow to the brain gets plugged. Now, when you were studying myocardial infarction, they told you about how the little vessels in the heart, as they get smaller, a clot will somehow block that blood vessel and cause that muscle to spasm. This is basically an ischemic brain attack, is basically a heart attack of the brain. A blood vessel gets plugged, and that area of the brain that's fed by that blood vessel is now being deprived of oxygen. You deprive an area of the brain of oxygen, the tissue dies, you get necrosis. So our goal is to get blood back to that section of the brain as quickly as possible. Now, I want to point out, hemorrhagic, which we'll talk about more in a minute, is where you actually pop some plumbing and you start bleeding into the brain. But 80 to 85% of all CVAs are going to be an ischemic brain attack. They're going to be a blood clot in the brain. And the same reason that so many older people get heart attacks is the same reason that some older people get strokes. It's because of these different risk factors down there. You risk throwing a blood clot. And there are risk factors. If you look at these risk factors, age, sex, elevated, especially hyperlipidemia, because you got extra fat running around the blood. All these are the same risk factors you have for a heart attack. So anything that's going to increase the probability that you're going to throw a clot is going to increase your chance of having a heart attack, and it's going to increase your chance of having a stroke. But the fastest way, let's see if it's on the next slide. Oh, something there you might want to remember. Okay, it's actually on the next slide over here. Well, let's go back though. So the ischemic cardiovascular accident is basically a heart attack. This is what you will mostly find. You're walking through the mall, somebody sits down, they slump to one side, They try to talk, but they can't. They may complain of a headache, dizziness, falling, numbness, tingling, blurred vision, etc. These are all subjective. There are definite objective characteristics about a CVA. And I'm going to explain what those are. And they've even incorporated it into what they call a BFAST test. Actually, there should be an E in here, but whatever. There is a test, a quick test that can be run by you as a civilian out there, and it's also used by paramedics. We use a version of it in the ER when we're doing a basic assessment of the patient. But as we get into this clinical and we start doing the head to toe assessment, there will be a more detailed assessment of the patient to determine exactly where his deficits are. But BFAST is just a quick 1, 2, 3, 4. This guy's having a stroke. Let's get him to the hospital. And this is what you'll see the paramedics doing in the field. Every once in a while, someone will throw a blood clot. And fortunately, the brain will, or the system will be able to dissolve it or resolve it in some way. Usually the blood clot will just solve or it'll pass. And then the individual will lose the deficits and return to normal. It might be just lost of vision for a second. If it's an occipital CVA, they may have lost their motion. If it's a frontal, they may have had one side go weak for a minute, but now it's back. Any of the classic stroke signs, they come and then they go. We call that a transient ischemic attack or a TIA. We used to call these warning strokes because, okay, you got lucky this time. Next time you won't be lucky. Next time it's going to be permanent. So that is kind of something to look out for. If you have a family member or somebody, or even a patient who, my left arm just went numb for no reason, but I'm okay now. No, you're not okay. You need to go to the doctor. You need to be checked out because you may need to get on some kind of anticoagulant to make sure you don't have another stroke that's going to be permanent. And just to say that, in an ischemic, you're cutting off the area of a brain. If it's cut off for long enough and the tissue dies, you lose that function permanently. For example, we've seen people where the right side goes slack. On a serious stroke, that function is not coming back again. Hopefully, if we can resolve it quick enough, use clot busters or different other drugs, you might be able, through rehab, to eventually get that function back again. And there's also, the brain is very adaptable. So you can lose a function, you can have a part of the brain actually die, part of the tissue in the brain die, and another part of the brain can pick up where that part left off. Sometimes it can, sometimes it can't. It's not an exact science. You may lose the ability to speak, your brain may be able to adapt, and through speech therapy, you may be able to speak again, or you may never be able to. It's really, toss the dice in the air and see where it falls. The brain is adaptable, but only to a certain point. Angry bug. Here's the BFAST test I was telling you about. Now, normally you're out there with your family member, grandma's walking along, and suddenly she feels out of balance and she sits down and says she's having a hard time seeing. Okay, these are subjective right here. This is what they are. This is what the patient's telling you. So you sit them down and now you start your test. Fast, face, facial droop. You look at the patient and you say, smile for me. And one side goes up. Well, that means they have facial droop on the left side. Classic sign of stroke. Don't confuse it though with a long-term disease called Bell's palsy, which some people have been getting from the COVID vaccine. Bell's palsy will cause facial droop, but that's all it causes. It doesn't affect anything else. And it's over a long period of time. So don't confuse that with stroke. But anyway, you'll see a person. Another one is to stick the tongue out and say, go right and left. If they can't go to the other side, it's a neurological problem, indication of a stroke. Arms, we normally tell the person, put your arms out in front of you, and close your eyes. Close your eyes, and if they had a neurological deficit, one of the arms will start to drop. We call that drift. So if you got the person sitting there and they close their eyes and their arm starts going like this, they have right arm drift. Classic sign of stroke. Speech, there again, going back to where we talked about in the beginning, aphasia, expressive aphasia. They're not getting the words out. You can ask them some simple questions. Who's the president of the United States? What day is it? Things like that. So this is just a real quick 3 characteristic test right here to objectively tell if somebody may be having a stroke. The T is for time. Time is of essence because there's an area of the brain that's not getting oxygen. We want that brain part to get oxygen. So if we wait too long, the tissue will die. And I'll tell you about what those are. Before I go into that, though, I need to talk about hemorrhagic stroke, because we're going to be comparing those two when I talk about diagnoses. The hemorrhagic is basically a brain bleed. That's where you pop a gasket in your brain and you start bleeding out. A lot of different things can cause that. Cocaine and methamphetamines, usually through the super high blood pressure, you blow a gasket. An infarction, not so much. I don't see that a whole lot, but that's where a vessel gets plugged and pops. The most common cause is malformation. And this is also called AV malformation. AV standing for arterial and venous. As blood vessels go into your brain, they go from being an artery, carrying oxygen, carrying blood into the brain, and then eventually become veins, which carry the unoxygenated blood out of your brain back to your body. They're very, very tiny vessels, and every once in a while, the veins get kind of all knotted up. Now, this is a genetic characteristic. You're born with it. There's nothing you can do about it. Most people don't even know they have them. But what you have the artery coming in, and then you have the veins coming out, and the veins look like a tree, like the root ball from a tree is the best description for it. I might get a picture and put it in here eventually. But you have this nasty, convoluted group of veins coming out of the brain, and they can have a tendency, because of the convoluted nature of them, to pop. And if one of those pops, you begin to bleed into your brain. There again, high blood pressure doesn't help any, because the higher your blood pressure is, the more likely one of these things is going to pop. And when that happens, you do experience the same neurological deficits that you do under an ischemic stroke, but they usually progress very quickly if it's a big bleed, or very, very slowly if it's a tiny bleed. There again, if the blood vessel pops and it starts just bleeding profusely, the person is probably going to go down within 5 or 10 minutes, and there's nothing we can do about it. I had one friend who had bad vessels in his brain from Agent Orange, from Vietnam. And he started getting a headache. The vessel, he got a severe headache. He got deficits on one side, and within about 3 minutes, he was dead. So it just progresses extremely quickly. Small bleeds, however, can take place over hours and days. And what usually happens with those is the person may experience a headache, maybe some nausea and vomiting because of the pressure in the brain. You go in and the doctor decides to do a CAT scan, and he sees there's a bleed. Now, as it bleeds, it's going to put some pressure on the brain. And as we know, anytime you cut yourself, you stop the bleeding by putting pressure on that spot. Maybe the bleed itself will exert enough pressure that the bleeding will stop. In cases like that, the brain will usually fix itself. and we just watch it. You'll be going in for frequent CT or MRI scans, and they'll make sure the bleed doesn't get any bigger. And then if it eventually your body will digest that blood back in and it'll go away. If it continues to bleed, the doctor can actually go in, open up your skull, get in there, clip off the vessels, and you're okay. They call it a aneurysm clip. So you can, it's not always a death sentence if you get an aneurysm, but we all the time will hear like, oh, here's a movie star. He was 23 years old and fell over dead from an aneurysm. That's because genetically speaking, he probably had this AV malformation in his head, and one day it just popped. Nothing we can do about it, except realize how precious life is. Moving on, there's really not much we can do about that. But the reason I need to tell you about the hemorrhagic strokes is because somebody has a stroke. And it's like, whoa, okay, get them to the hospital. We throw them in an ambulance, we race them to the hospital. And first thing we do is we race them into the CT scan. Why do we do that? Please.
Like we want to know if they're bleeding or if there's a clot.
Exactly.
So they can do TPA maybe or not.
Exactly. One of the primary methods, I don't know if I have it on here. No, I don't. One of the primary methods of treating a stroke is to give it a clot buster. Clot buster is like heparin on steroids. It's a real heavy anticoagulant. But if we wind up giving that clot buster to somebody who has a hemorrhagic stroke, what are we going to do? We're going to kill them. We just made them bleed more and bleed faster. So the first thing we have to do when somebody comes in the ER is determine, do they have an ischemic stroke or do they have a hemorrhagic stroke? And they look distinctly different in a CT scan. Now, the minute the doctor finds out this is an ischemic stroke, we rush them out of CAT scan back into the ER, and we try to treat that ischemic attack. And usually it's with a drug called TPA, which is we also call clot buster. And like I said, it's like heparin, only very, very powerful. And hopefully it will help dissolve the clot and help the person to get their neurological functions back. They can do surgery if they feel it's necessary. I've rarely seen that. But unfortunately, when the person gets ready to do TPA, we have a list about this long of questions we have to ask them. Have they had a surgery recently? Are they on anticoagulants like, I just had a TIA. And the anti-clotting drugs like heparin or warfarin, Coumadin, that's the word I'm looking for. If they're on those, they can't get the TPA. If they had a recent surgery, they can't get a TPA. They have any kind of clotting problems, they can't have TPA. And so there's a long list of questions we have to ask them or a family member before we can actually give them the TPA. And if they can't take that, then usually the stroke procedure is more a matter of getting their blood pressure down and just hoping it will resolve itself. There's really not a whole lot beyond that we can do. I've had to give TPA as a nurse. That is what you will be doing. You will be shaking the vials, you will be administering it to it, and you'll be watching the patient. So if you decide to work in the ER and you decide to work with stroke patients, that's one thing that you're going to be doing. That's all on us, guys. And here's some other tests that can be used to get more detail. They probably use those more in the case of a hemorrhagic stroke than they would of a CVA. Now, there again, as the person goes through the stroke, you may see some of the neurological functions begin to resolve. Whether or not you gave TPA to the patient, that's a good sign. Other times you will you'll see no progress, and they risk the possibility of having permanent stroke damage. Only other thing I'm going to say about stroke patients is 99.9% of the time when we get a stroke patient, the first thing we do on the floor is we put them on swallow precautions. For some reason, strokes really affect your ability to swallow. There again, it's affecting the neurology of the mouth and throat. So if you do get a stroke patient if you admit a stroke patient to your floor, you want to take a careful look at that. Make sure that they're on swallow precautions or that they have been evaluated for their swallow reflex. And usually it's the speech therapist that does this. She will do an evaluation on the patient and determine at what level they can swallow. Now there's regular swallowing, there's solid food or thick fluids only, because when you have trouble swallowing, most trouble will be with very liquidy, very fluid substances like water. You may be able to swallow Jello, but you can't drink water. So we call that soft diet. So there's different levels of swallow precautions that you will have for your patient. Any questions on any of that? Person will basically move from this point into physical, occupational, or speech therapy to try to rehab whatever function we can get back to them.
Yeah.
That's all I got for you today. Are there any questions on any of it?
Thank you.
You're welcome. I will get this posted and I will get it uploaded to the site.